everybody. Good evening to you. I'd like to start with thanking all of you for being present for this CML update, which we have planned to be a virtual program. My pleasure and honor to welcome you to this CML update. So, ladies and gentlemen, quite a lot of people, particularly in the West, they believe that CML is, kind of treatment for CML is pretty much established, and it is a disease which is dried and dusted, and nothing more needs to be done on the CML front. But unfortunately, in India and in other low middle income countries, the reality on the ground is quite different. Almost even if you start imatinib to all patients of CML, only about 60 to 70% remain on imatinib for various reasons. And the most worrying reason for us is that there is suboptimal response to imatinib, or after an optimal response, there is a molecular recurrence of the disease. So I'm not going to highlight on the importance of now have the availability of all the three generic versions of the second generation tyrosine kinase inhibitors. We have generics of dasatinib, bosutinib, and nilotinib. However, the third generation TKIs, ponatinib and asciminib, are not available, and we are really looking forward to the launch of asciminib, which should happen in the first quarter of next year, or at the most in the second quarter of next year. So we will have a molecule available to us for the multi-tyrosine kinase resistant patient, and also for the patient who has the dreaded 315I mutation. Compliance in our part of the world, and in fact in every part of the world, is a big issue. So that is the first thing which you have to ensure for a patient who's not doing well on a first and also on a second generation tyrosine kinase inhibitor. And then molecular monitoring, as I said, looking for imatinib resistant mutations is again important. And these are some of the aspects which we will cover and thrash out in today's virtual CME. So the way we have structured the program today, and many thanks to Dr. Lalit Mohan Sharma for helping me structure this program, is that we will have lectures by two experts to start with, 20-minute lectures followed by question answers after each lecture. Excuse me. And then we will follow this up with a panel discussion in which real world cases will be discussed. So the first talk is going to be by Dr. Upender Sharma. I think all of you know Dr. Upender, first DM in clinical hematology in the state of Rajasthan. He did his DM from KEM Mumbai. One of the finest hematologists, certainly in the state and possibly in the whole country. And Upender is going to talk to us today on unmet needs in CML. Something about intolerance, resistance with the various TKIs, first generation and second generation, which we see in daily practice. So over to you, Upender. You have 20 minutes. And may I please request you to call the next speaker, which is Dr. Manoj Mahajan, when you finish the question answers for your session. Over to you, Upender.
Yes, sir. Can I share my screens?
No, sir.
Hmm?
Yes, sir, you can.
Can you see?
Yes,
Yeah,
sir.
I can see your slides, and please go ahead. Thank you.
I am thankful to Dr. Hemant Malhotra, sir, for that kind introduction. He is always an inspiring force for all of us, for young all hematologists and oncologists. He is our mentor, teacher, and guide since the MBBS days. I'm also thankful to Dr. Lalit Mohan, sir, team Novartis, for giving me an opportunity to speak on today's presentation. Today, I've been asked to speak on the unmet needs in CML, intolerance and resistance with TKI use in later lines. So we know this survival of CML by era in 1980s, it was around 8%, and in 2021, it is around 92%, more than 92%. So treatment discontinuation by TKI, efficacy failure predominates in the early lines of treatment, while intolerance is a major reason for discontinuation in the later lines of the treatment. The TKI availability for CML by the line of therapy. As you know that as the subsequent line of therapy increases, we have lesser availabilities of TKIs that we can offer to our patients of CML. So with a third line of TKIs, or only 2 to 3 TKIs available. Those patients with T355 mutation is the dead end mutation, a death sentence for most of our patients. Availability of ponatinib is not in India. Ponatinib is available outside our country. And now we have asciminib, a STAMP inhibitor that is recently had FDA approval for those patients with T355 mutation, and also for those patients who have failed more than 2 lines of therapy. So it is an option for those patients. So we know that as the subsequent lines of therapy increases, those patients are more subset of those patients are candidates for allogeneic stem cell transplantation. So failure rates increase in the later lines of therapy, as we know that when patient is used imatinib in the first line, and in the second line of second generation TKIs as upfront, the failure rates is to the tune of 31% and 13%. And in the second line setting, this rate increases to 50 and 60%. And the third line setting, it increases to 75%, 80%. So the ultimate failure rates for imatinib upfront when used as front line is 12%, and for second generation TKI is 6%. This is a huge number. So we had a very unmet need for those subset of patients who have failed more than 2 lines of therapy with CML-CP. So those subset of patients, a novel therapeutic option is needed. And we'll discuss it for that in our subsequent talk. So what are the long-term outcome after multiple TKI failure? So the long-term outcome for those patients who have failed multiple TKIs is poorer than their first-line outcome. So the blue line is for those patients who have failed 2 TKIs, and green is for those patients who have failed more than 4 TKIs. So we can see the overall survival and transformation-free survival is better for those patients who have failed lesser lines of therapy as compared to those patients who failed more lines of therapy, 3 or more lines of therapy. So the outcome of patients failing second generation TKI is further poor. The 24 months event-free survival is around 60%, and progression-free survival is 45%, and the overall survival is in the tune of 60%. When we can see when second generation TKI is used as a third line treatment for patients of CML-CP, in various studies we can see that the attainment of complete cytogen response rate is in the tune of 10 to 30%. And those patients achieving measurable response rates is further less, 10 to 20%, with lesser event-free survival and overall survival for subset of patients. So comparative efficacy of third-line TKI therapy for achieving complete cytogen response rates. So those patients wherein they are receiving third-line TKIs, so the probability of achieving a complete cytogen response rate is less than 30% for those subset of patients. We can see those patients who failed imatinib and dasatinib attaining a complete cytogen response rate is 20% with bosutinib and 27% with nilotinib. Those patients who failed imatinib and nilotinib, probability of attaining a complete cytogen response rate is less than 30% with bosutinib and dasatinib. Here, ponatinib third-line generation has a promising results with more than 50 to 60% attainment of complete cytogen response rates. So second generation TKI in CML-CP post imatinib resistance, so 4 to 7 year discontinuation rates with second generation TKI in second line setting is tuned to the of 70%. So matching adjusted treatment in direct comparison of second line TKI in second line. So those patients who have received dasatinib and bosutinib as it was compared indirectly. So we can see the lower probability of PFS probability for nilotinib and dasatinib. Red line is for nilotinib and dasatinib, and green line is for the bosutinib. So bosutinib patient, they have better PFS as compared to those patients with nilotinib and dasatinib when it is used as second line therapy in patients of CML-CP. So considering the next treatment option, so we have to see what further therapies are available for patients of CML, other TKIs, or availability of stem cell transplantation if patients have failed multiple TKI or those with T355 mutation. So what is the expected efficacy of that those options? What is the local experience, example in the stem cell transplantations? And what is the safety of various comorbidities and various safety profile of the TKIs that has to be taken into the consideration. So let's discuss about ponatinib. Ponatinib is again the results of ponatinib after second generation TKI failure in chronic phase CML. So we know that those patients who failed a second generation TKI, their prognosis is not that good. So with another second generation TKI. So phase 2 PACE and OPTIC trial evaluated outcome of CML-CP patients, those who have failed a second generation TKI, either dasatinib or nilotinib. So PACE study showed that those patients who have resistant or intolerant to dasatinib or nilotinib, they had deep and durable response with ponatinib, but with the increased rates of arterial occlusive events. And in OPTIC trial, this was shown that the promising results were there, and good part in that trial, OPTIC trial, that the arterial occlusive events were less because the dose of ponatinib was decreased from 45 milligram to 15 milligram when this patient has achieved BCR-able transcript less than 1%. So thus decreasing the arterial occlusive events from 20% to 5%. So efficacy of PACE and OPTIC post failure of first failure of second generation TKI. The BCR-able transcript less than 1% at 24 months is due to the 45 to 50% in these trials. PFS is at 2 years is around 67% PACE and 87% in OPTIC trial. Overall survival at 2 years is 85% in PACE and 93% in the OPTIC trial. So we get the safety aspect of these TKIs. Failure of after failure of second generation TKI. So we can see the arterial occlusive events were tune of 20% with PACE trial, where ponatinib was used in the dose of 45 milligram. In OPTIC trial, these rates were 5%, 1/4, 5%, where ponatinib dose was decreased from 45 milligram to 15 milligram. Once patient has achieved BCR-able transcript less than 1%, thus decreasing a rate of arterial occlusive events to 1/4. So now we discuss about bosutinib. The response to bosutinib as third-line therapy, it is a dual SRC and ABL inhibitor, no effect on c-KIT or PDGFR. Around 115 patients who have failed imatinib 600 milligram or dasatinib or nilotinib, they were taken. 3 cohorts were there: imatinib and dasatinib resistant, imatinib and dasatinib intolerance, and imatinib nilotinib resistant. So attainment of complete cytokine response rate were tune of 14% with dasatinib arm and 27% with nilotinib arm. Major molecular response rate were not good with this bosutinib. Major molecular response rate with 3% with dasatinib arm and 11% with nilotinib arm. So is stem cell transplantation a good option for patient of CML who have failed 2 lines of therapy with TKIs? So we can see the upper graph is for the CP patients, middle and lower is for the accelerated and blast crisis. Blue line is for the ponatinib, and the red line is for the stem cell transplant patients. We can see that the survival benefit for ponatinib in those patients who are CP, and in accelerated and blast crisis, we can see that stem cell transplantation results were better as compared to ponatinib. But in this chronic phase CML patients, ponatinib survival curves are better as compared to the stem cell transplantation. The MD Anderson Cancer Center outcome with allogeneic stem cell transplantation after failure of multiple TKIs. So those patients who failed 2 or more TKIs, the results when they were subjected to allogeneic stem cell transplantation in chronic phase, results were better. Blue line as compared to those patients who were transplanted in advanced phase, blast crisis or accelerated phase, yellow line. So survival probability and event-free survival, overall survival were better when they were transplanted in the chronic phase. So do you think that newer treatment options are needed for these subset of patients who have failed multiple lines of therapy? So needed newer treatment aspects with TKIs. Asciminib is an allosteric inhibitor, STAMP inhibitor, pivotal phase 3 trial, ASSEMBLE trial, compared asciminib with bosutinib. Dasatinib is the second generation TKI approved in South Korea as first line and second line, pending studies elsewhere. PF114, it's another, it is ponatinib analog, not binding with VEGFR. Phase 1 completed. Other 2 options we are in phase 1 study, which are active against T355 mutation. Various mutations which are targeted by ATP binding sites, blue mutations, and the myristoyl binding site, red mutations. Various mutation profiles for various different TKIs. So as use of asciminib, those patients receive asciminib more than 3 months. So what were the results in T355 subset, and those patients were not T355 mutated? So we can see the attainment of complete cytokine response with asciminib in those subset of patients who are not T355 mutated is into tune of 70% as compared to 44% in those patients with T355 mutation. Attainment of major molecular response rate at 12 months is in the tune of 48% in non-T355 mutated patient and 28% in those patients with T355 mutation. positive. So attainment of major molecular response rate in those patients who have failed 2 or less than 2 TKIs is at 12 months, major molecular response rate were 47% in non-T355 mutated patients as compared to 38% in T355 mutated patients. Those patients who failed 2 or more than 2 lines of TKIs, attainment of major molecular response rate is further less in this subset of patient, with 34% in non-T355 mutated patient and 11% in T355 mutated patients. So those patients who failed ponatinib, either they are resistant or intolerant. The attainment of major molecular response rate at 12 months is 40% for non-T355 mutated patients and 17% for T355 mutated patients. So those patients who failed ponatinib, we don't have much available options, and asciminib is a reasonable option for subset of patients wherein we can attain major molecular response rate in the tune of 15 to 20%. So first, summarizing first part of my talk. So with each line of treatment with TKI binding TKIs, failure rates increases. Thus, novel treatment options are needed for patients who have failed 2 or more lines of therapy. Over survival and transformation-free survival decreases post second line of treatment with TKIs. Ponatinib can be considered as an efficacious option for patients. However, safety is an issue with more evidence of arterial occlusive events and venous thromboembolism. Bosutinib provides a reasonable efficacy in third-line setting. Stem cell transplantation is not a feasible option for patients with CML-CP. Hence, there is a need for newer alternative therapies for patients who have failed 2 or more lines of therapy, or those who are positive with T355 mutation. So, intolerance and the importance of health-related quality of life in clinical practice. So off-target effects of kinase inhibitors can impact drug safety. So red bar is for the kinase, various kinases. So imatinib and nilotinib, they have less off-target effects as compared to bosutinib, ponatinib, and dasatinib. So adverse events leading to intolerance may occur with the TKI use. We can see the fatigue, gastrointestinal disturbances like diarrhea, vomiting, hematotoxicities like cytopenias. They are the most common side effects of the various TKIs. These adverse events can be managed with dose reduction interruptions, and these side effects impair the quality of life of these patients and can lead to discontinuation of the therapy. So TKI intolerance is a common reason for discontinuing CML therapy. Up to 30% discontinuation due to TKI due to adverse events in various TKI trials. When we can see when used in the first line setting, various TKIs, first generation, second generation TKI, discontinuation rates with imatinib in ARIS trial was 4% as compared to around 10% in those patients who are using second generation TKI in first line. Those patients were in second line, they are using TKI in second line, or those with T355 mutation, we can see the discontinuation rate is in the tune of 20 to 30% in such subset of patients. So do treatment discontinuation in clinical trials also resonate with the discontinuations in the real world? This answer was given by Simplicity trial. This was an observational study comparing TKI use in management of patients of CML-CP in Europe and USA. More than 1,000 patients were taken from 2010 to 2017. First-line treatment with imatinib, dasatinib, and nilotinib. Treatment interruptions, discontinuations, and switching were analyzed for subset of patients. So treatment interruptions in the first year of follow-up were in the tune of 16% versus 4% in the second year. So we can see in the first year, the most common reason for the discontinuation was hematologic toxicities with thrombocytopenia and neutropenia. In the second year, the most common reason for discontinuation was pulmonary events with dyspnea, pleural effusion, and fatigue. So treatment discontinuations were reported in 21% of the patients in the first year and 10% in the second year. So more cases of discontinuation were seen in the first month of therapy. Intolerance was the most common cause of discontinuing therapy in the first year, and resistance was the second most common cause of discontinuation in the second year of treatment. So switching after discontinuing from first-line TKI in the first year of treatment was in the tune of 17% versus 10% in the second year. So intolerance was the most common reason for switching of the first-line TKI in the first year of treatment. And most common cause for intolerance was GI disturbances. In the imatinib group, GI disturbances, musculoskeletal symptoms, connectivity disorders, and rash were the common cause for discontinuation. In dasatinib arm, pulmonary toxicity with pleural effusion was the most common cause. In nilotinib arm, GI disturbance and rashes was the most common cause. Primary resistance was the second most common cause for the discontinuation of the TKI in the first and the second year of the treatment. So let's look at the individual adverse event spectrum with each of these TKIs. With the imatinib, we know that the most common adverse event was fluid and retention and edema. Myalgia, hypophosphatemia, GI disturbances were other causes, other side effects. Nilotinib causing pancreatic elevation, indirect hyperbilirubinemia, and QT prolongation. Ponatinib causing hypertension, arterial occlusive events, venous thromboembolism. Dasatinib causing pulmonary toxicity with pleural effusion, pericardial effusion, and bleeding risk. Bosutinib causing gastrointestinal symptoms like diarrhea, nausea, vomiting, rashes, and pleural effusion. Common toxicities with various TKIs was hematologic toxicity with myelosuppression, transaminitis, and electrolyte imbalance. So cardiovascular, pulmonary, and metabolic adverse events with the existing TKIs. Imatinib can cause congestive heart failure, left atrial dysfunction. Pulmonary toxicity is less with imatinib. Dasatinib having more pulmonary toxicity as compared to the cardiac toxicity. Nilotinib can cause QT prolongation, cardiac and arterial vasovagal events were there. Hypertriglyceridemia and hyperglycemia is a side effect with nilotinib that has been taken into the consideration when using this drug. Bosutinib causing cardiovascular, pulmonary, or metabolic toxicities. It is infrequent with bosutinib. More common adverse event with bosutinib with the gastrointestinal symptoms. Ponatinib leading to vascular arterial occlusion, venous thromboembolism, arrhythmias, and possibly pulmonary hypertension. So can we, the understanding of these adverse events can individualize treatment of patients with CML. So once we are selecting any TKI, we have to consider age of the patient, medical history, comorbidities, and the adverse side effect profile of the TKI we are using. So those patients who are having pulmonary toxicity with pleural effusions, lung disorders, uncontrolled hypertension, we have to avoid dasatinib. For pulmonary arterial hypertension, we have to avoid dasatinib. Risk of hemorrhagic complications with patients taking anticoagulants, this risk is increased with dasatinib and imatinib. With uncontrolled hypertension, we have to use nilotinib with caution. With coronary, cerebrovascular, and pulmonary artery hypertension, nilotinib use is to be with caution. Hepatic impairment, dose of bosutinib has to be decreased. Long-term use of imatinib can cause renal impairment. So cardiovascular adverse events is a class effect of various TKIs. We can see with the instant trial, decision, and before trial, the cardiovascular events were more with nilotinib, dasatinib, and bosutinib as compared to the imatinib. The higher incidence of pulmonary events and pulmonary arterial hypertension with dasatinib versus nilotinib versus imatinib. We can see in decision trial the higher rates of pulmonary events with dasatinib as compared to the imatinib. Gastrointestinal adverse events can occur with all TKIs. Diarrhea rates were higher with bosutinib, dasatinib, and imatinib. We can see with gastrointestinal events were more with imatinib in the instant trial, more with imatinib as compared to dasatinib in decision trial. But before trial, gastrointestinal events were more with bosutinib as compared to the imatinib. So higher incidence of fluid retention with imatinib versus second generation TKI. In various trials, instant trial, decision, and before trial, we can see the second bar is for the imatinib, first is for the second generation TKIs. We can see the fluid retention was more with imatinib in instant decision before trial. So imatinib having tendency of more water retention, facial puffiness, pedal edema as compared to various second generation TKI. So in patients with CML, the Yes, yes. So in patients with CML, the quality of life worsens by the disease stage and the line of therapy. As we know that the quality of life is measured by various parameters. So it is significantly lower for patients with CML in acute phase of blast crisis as compared to chronic phase. The quality of life was also significantly lower for patients who were receiving second line or third line treatment with the TKIs as compared to the first line of therapy. So these results stress that the importance of treatment adherence to prevent disease progression to acute phase of blast crisis. So healthcare cost increases after each line of therapy. As you know that patient when is using first line or second line or third line therapy, the cost of therapy increases with the use of subsequent line of therapy, and the response rates are not that good as compared to the first line of therapy. So in the real world, also the cost of therapy increases, the line of therapy increases. So do you know that, do you think that there is any structural or event or quality of life tracker that can help patients of CML when we can see their well-being aspects? So there is a health-related adverse event tracker. Points are given in the score of 1 to 5. Patient can assess his adverse events with various parameters on this parameter on this tracker, and these can be recorded and this can be discussed with the doctor, and then we can assess the health-related quality of life of these patients. So summarizing my talk, the treatment guidelines indicate that the specific safety profile of individual TKI should be considered when we are selecting a particular TKI. Factors that impact the quality of life include adverse events and toxicities that should be taken into the consideration. Therapy should be individualized in CML patients with a specific history of comorbidities. TKI intolerance is a common reason for discontinuing CML therapy, and we know that 30% of discontinuation rate is because of the adverse events in various TKI studies. Data from the Simplicity study indicate that the intolerance is the major reason for switch in the first year or second year of the treatment. In patients with CML, the quality of life worsens by the disease stage and the line of therapy, and regular monitoring of adverse events and patient quality of life is recommended for better outcome. Thank you for that patient hearing. And thanks and sorry for that technical glitch. So any questions that are welcome. So now, if there are any questions, we'll discuss those questions or we'll proceed to second talk. Now I invite for next talk. This is regarding emerging therapies for CML in second line and those patients with T355 mutation having. So for this talk, I'm inviting Dr. Manoj Mahajan. The chairperson for this will be Dr. Suren Beniwal, Dr. Govind Patel, and Dr. Lalit Mohan Sharma, sir. Over to Dr. Manoj for the next presentation.
Thank you, Dr. Upendra. So I have been given like emerging therapies for CML in second line plus therapy and T315 mutations. I'll just share my screen. Sorry. Is it visible?
Yes, sir. We can see the screen. Please continue.
Yeah. So first of all, I would like to thank Dr. Hemant Malhotra sir, Lalit Mohan Sharma sir, and Team Novartis for arranging this session. And Dr. Upendra has done like half of my work has been done by Dr. Upendra. And I would like to have a disclaimer that I haven't used any of the molecule I am discussing here. So this was totally new topic for me and new learning for me as well. So most of the time, if the patient worsens, like especially in the crisis phase, we usually refer. We don't have a facility in Udaipur, so we usually refer patients to uh, higher centers wherever the transplant facilities are there. So Dr. Upendra will be a better guide if there are any questions or glitches, not technical, like medical glitches. So I would like to add whatever theoretical I have read or gone through this topic. So emerging therapies for CML in second line plus and T mutation 3151I mutation patients. So we'll be discussing like mainly there are bosutinib, which is fits in the third line setting where there is no T315 mutation. Then ponatinib is a potent molecule which fits in third line as well as the patients with T315 mutations. Then the asimetinib is one molecule which can fit probably into both the indications where bosutinib and ponatinib fits in, and the newer molecules which will just flip through like oliverembatinib and odobatinib. Few slides will just go through. So what is the mechanism of action of bosutinib, ponatinib, oliverembatinib, odobatinib, and asciminib? So if you look at bosutinib, as already discussed, it is dual kinase inhibitor, BCR-ABL kinase, and SRC kinase. Like BCR-ABL is constitutively active and drives the downstream growth pathway. Ponatinib is a molecule where like T315 mutation and BCR-ABL kinase is there. It has action against in this subset, but it is a multi-kinase inhibitor as well. Like apart from BCR-ABL, it also inhibits SRC, FGFR, PDGFR, VEGFR, FLT3, RET, and c-KIT mutation. And asciminib is an allosteric inhibitor of BCR-ABL, so it has a different sites. Probably that is the one reason where it shows it has activity in T315I mutations. So it is a specifically targets ABL myristoyl pocket. It's a STAMP inhibitor, so which is known as STAMP inhibitor, and does not compete with the ATP as compared to other TKIs which compete with the ATP. So coming to the bosutinib in third line populations, so it's a beyond study. The study design is phase 4 study, and it studied the effect of bosutinib in patients with CML resistant or intolerant to prior TKIs. So inclusion criteria for most of the subset I'll be discussing is more adult patients with Ph positive CML, CP, AP, or BP, patients treated with more than one TKI or intolerant to TKIs, and in bosutinib or beyond study, as we have seen in the mechanism of action, it does not have action on a T315I mutations. So these were excluded in these trials. So primary endpoint was cumulative confirmed major cytogenic response. So if we look at the enrolled patient, nearly 163 patient, CPCML 150, most of them were CPCML. Second line, nearly one third of each were second line, third line, and fourth line. Half of them were resistant, and nearly half of them were intolerant. So what were the result? At the end of, let's say 1 year, cytogenic remissions was nearly 2/3 patients. The major incidence of T was diarrhea, as we commonly know, almost 87.7%, and grade 3 were 16%. And the rest other toxicities were mainly GI related, including nausea, vomiting, abdominal pain, ALT increased, fatigue, upper abdominal pain, so asthenia. Most of them were GI symptoms related. And though the real world evidence says more patients discontinued bosutinib because of the diarrhea. So key takeaways were like in third line setting, there are nearly 2/3 patients respond, and in intolerant subgroup, nearly 81% has major MMR after treatment with the bosutinib. GI symptoms were more common, and in the real world setting, diarrhea could be treatment limiting, although the author suggested that it could be improved with the dietary changes, supportive care such as antidiarrheal or fluid replacement. So it is one of the strong competitor to other TKIs in this setting. So next is ponatinib. So the subset which were missing in bosutinib arm was third line as well as T315I mutation population. So in this study, PACE study, which had approval of in patients with CML, CP, AP, and BP resistant to or intolerant to prior therapy, inclusion criteria were same, and in addition to that, there were T315I mutations were added. Nearly 450 patients were enrolled. 270 were CPCML, rest were in other stages, and out of 270, nearly 64, we can say nearly 1/4 were T315I mutations. Starting dose was 45 milligram, and once the dose reduction were permitted. So coming to the efficacy of the study, if we look at the nearly 5 years of follow-up, PFS had nearly 50% in CPCML, as well as OS is nearly 75%, nearly three-fourths of the patients. And in 315 mutations, again, 50% had PFS at the end of 5 years, and OS nearly two-thirds at the end of 5 years. So that is quite significant. If we look at the setting, the third line setting, especially in the resistant 315 mutated arm, so that is one of the very critical. The bosutinib ponatinib has very significant role in such setting. So primary endpoint of MC cytogenic remission was achieved in nearly 56% of CPCML at the end of 12 months. Coming to the another study, which is an optic study. This was mainly designed. What was lacking in the previous study was the dose, but because of the side effect or TE associated with the ponatinib were quite significant. So dose reduction should be considered, and that is what is considered in this study. Mainly safety and efficacy of ponatinib over a range of 3 starting dosages. So which was effective, that we need to know. The inclusion criteria is more or less same. Nearly 300 patients were enrolled, randomized in 1:1:1 fashion, with ponatinib 45 milligram versus 30 milligram and 50 milligram. Dose reduction was allowed in cases of adverse events. So primary endpoint was less than 1% BCR-ABL at the end of 12 months. So if we look at the efficacy arm in interim analysis, MMR achievement was like nearly 14% with the 45 milligram and nearly 19% with the 15 milligram, and less than the major endpoint, less than 1% BCR-ABL at the end of 12 months was achieved more in 45 milligram arm as compared to the 30 or 15 milligram arm. If you look at the 315 status and without 315 status, this mutation had most of the patients responded in 45 milligram arm as compared to the 50 milligram arm. So probably the 45 milligram arm is more effective as compared to the 15 milligram. That is what it is showing. The interim efficacy safety, hematological toxicities were more of thrombocytopenia and neutropenia as compared to anemia. And if we look at the non-hematological toxicities, mainly hypertension, headache, lipase was increased, which was though clinically not significant. Hypertriglyceridemia, rash, abdominal pain were other side effects. So again, the efficacy at the end of 12 months we have seen, but after maintenance of the response after the dose reduction, after achieving less than 1%, this was also a subset studied where once the maintenance response is achieved, dose reduction was allowed, where the 45 milligram arm and 30 milligram arm are showing more or less similar results. So dose reduction can be considered if we have achieved less than 1% BCR-ABL. PFS is again in 15 milligram arm, it is 45.6 months, and in 30 milligram and 45 milligram arm, it was not reached. So patient receiving 45 milligram starting dose showed slightly higher probability for PFS, especially at the end of 36 months. For the OS, again similar, it is higher 36 months probability for the higher dosages. Safety, we have seen safety more or less. We have seen the safety arm. Except I would like to focus the second part of this slide, second half, the lower half. Rates of dose discontinuation, reduction, and interruptions were slightly higher in 45 milligram arm because obviously we expect more side effects. Though the upper half is not showing clearly, there are clinically significant differences between these three arms. Side effect we have already discussed with the optic studies and ponatinib. So we'll just flip through. So to summarize the PACE study, this PACE and optic study, these were the landmark studies which included T315 mutation as compared to the bosutinib, and which demonstrated 45 milligram starting dose should be the ideal one, and then it can be reduced up once the less than 1% BCR-ABL1 achieved. It can be reduced to 15 milligram arm. It can show the effect. Mainly the tolerability was well tolerated, especially with respect to cardiovascular toxicity. We need to look into which were the major concerns. The next molecule and its trial was asciminib, which is again, as we have discussed earlier, once this in CML, the constitutively active BCR-ABL drives the growth. So asciminib has a different site, which is not as compared to normal TKI. So it's allosteric inhibitor in the myristoyl pocket. So this is what we are showing, and it is a non-ATP competitor as compared to other TKIs. So phase 3 assembled studies, as Dr. Upendra has mentioned in detail. So we'll be just flipping through the overall study. It is a phase 3 landmark study, again demonstrated efficacy and favorable tolerability profile in patients previously treated with more than 2 TKIs. And it was analyzed at 24 weeks, 48 weeks, and 96 weeks. So study, again, the key criteria were in the similar setting, more than 2 TKIs, adult patients, failure or intolerance of the most recent TKI. Patients with intolerance of most recent TKI must have BCR-ABL more than 0.1% at screening. No T31I5 mutations or V299L mutations. So this excluded mutations initially in this study per se. It has randomized in 2:1 against the bosutinib and asciminib in 2:1 fashion. Treatment duration was more than 96 weeks. So if we look at the week 24, week 48, and week 96 data, so primary endpoint MMR was more than double with asciminib as compared to the bosutinib at all the 3 intervals. So rates of BCR-ABL 1 at less than 1% in various intervals. These are, again, if you can see the picture. So it's more like it at each interval, week 24, week 48, and week 96. These are more than double as compared to the bosutinib arm. MR4 and MR5, 4.5 rates in the phase 3 assembled study. Again, deeper response rates with the asciminib as compared to the bosutinib arm at each interval. So it's definitely demonstrate the superior efficacy over the bosutinib. Most frequent hematological toxicities were mainly thrombocytopenia, neutropenia. Bosutinib, we have seen like the GI side effects are much more common. So these are much less. So side effect profile of asciminib is more or less tolerable as compared to the bosutinib. So in summary, to summarize both the arms like asciminib and bosutinib, ongoing treatment is nearly half of patients is still taking asciminib and continuing. Bosutinib only 20% patients are taking. MMR at week 96, nearly 1/3 patients. Here nearly 1/6 patients. MR4 at week 96, nearly 17.2% versus 10.2. MR 4.5, 10% patients, and merely 5.5 at MR 4.5 at week 96. So again, the subset analysis, or again, this design, the new study with the asciminib in T315I mutations. So it was a study arm 1, asciminib monotherapy, CML with this mutation. Dose escalation will allowed. Once the MTD is decided, then asciminib monotherapy in 200 milligram dose expansion phase. So in this studies, if we look at the clinical profile, only one mutation, nearly most of the patients. With other mutations, other 2% patients had additional mutations. BCR-ABL screening, if we look at most of them, more than 10%, more than half of patients had BCR-ABL screening more than 10%. And to conclude, cohort of this study, all patients week 24 nearly 42 versus 48%. Ponatinib naive patients had better MMR rates as compared to the ponatinib pre-treated patients. Cumulative MR 4.5 and MR 4 and MR 4 rates in 315 cohort were higher as compared to the in other arm like week 24 and week 96. So side effect profile, discontinuation was nearly 10% patient discontinued because of the toxicities. as compared to what we had seen in the ponatinib arm. Side effect profile were more or less most of the lipase increase was asymptomatic and there was no clinical impact. Most common grade 3 adverse events were occurring nearly 5% of patients, which was mainly lipase increase in thrombocytopenia, vomiting, ALT, abdominal pain, hypertension, anemia, neutropenia. So we have summarized all the findings. So we'll just flip through the next few molecules in last few slides. So olivembatinib, third line and 315 patient populations. This is again phase 2 trial, single arm, multicentric, open label study evaluating efficacy and safety of this molecule, which is in the patients. So patient inclusion criteria were patients with TKI resistant to CML AP harboring 315 mutation. ECOG PS was less than 2. No patients with prior ponatinib or olivembatinib treatment or with uncontrolled cardiovascular disease were included. So primary endpoint was MAHR, so that we can see oloprenib was administered nearly at 40 milligram QOD for 28 consecutive days as per the cycle over 24 months, and more than 6 completed cycles was seen in nearly 18 patients against the 23 enrolled patients. So to summarize, it has a nearly 60% patient achieved complete cytogenetic remission and evaluable patients, and MMR rates were nearly 37%, so one-third patients. So it was mainly promising efficacy data in Chinese patients in T315 mutation. So mainly hematological toxicities, liver toxicities were limiting for the olivembatinib. And the last molecule we'll be discussing, odobatinib, third line patient populations. This is a phase 1 study, safety and efficacy of odobatinib in CML CP patients failing TKI therapies, including ponatinib. So inclusion criteria, again, pH positive CML patients who failed more than 3 TKIs or less. So it is a phase 1 trial. If we can look at the ponatinib naive and ponatinib treated patients, both the arms were more or less comparable. So ponatinib naive patients were 15, ponatinib treated patients were 16, and the summary was like MTD was as nearly 174 or 200 milligram respectively. Efficacy of in ponatinib treated patients despite higher number of previously TKI treatments. Efficacy was comparable in both the ponatinib treated and ponatinib naive patients. So this could be a upcoming or emerging option which we can think about once there is more data. So I think we have discussed most of the things. Do we have time?
Yes, Dr. Manoj, continue.
Yes. So key takeaways is ponatinib is one of the multi-targeted TKI capable of inhibiting BCR-ABL with gatekeeper 315 mutations. Ponatinib is not effective against some 315 mutation compound mutations. So in cases of compound mutation, we need to have some other options apart from ponatinib. BCR-ABL can be one of the option. It's a dual kinase inhibitor in third line setting where there are no mutations. And then olivembatinib and ponatinib can inhibit 315 mutation. If these are available, we can try or we can have more data before practicing it in clinical setting. So asciminib is one molecule which can fit in third line setting plus single mutation setting. And I guess the side effect profile are also minimum as compared to what other TKI lines, like as we have seen Dr. Last slides of the Dr. Upendra Sharma sir's slides. As the number of lines or number of therapies are increasing, the side effect profile also go on increasing. So asciminib will be a one molecule where it has apparently lesser side effects as compared to the most of the TKIs. Thank you.
So, Dr. Manoj, for those patients with T315 mutation, what are you doing?
So my thoughts would be like for 315 mutations, we can use ponatinib is one of the good option if there is only isolated mutations, and asciminib can be fit if it is available. I'm not sure if it is available in India. but these two options definitely are available as of now. And if in third line setting, as I said, bosutinib can be options in the absence of 3-on-5 mutation.
You can introduce for the next moderation.
Yes. I would like to introduce my good friend of mine, Dr. Deepak Shukla, for moderations. So thank you for all your presence here, and then please take us for the moderation for the further session.
Thank you, Dr. Manoj, and thank you, Hemant sir, Lalit sir. I'll be sharing my slide. Can you help me with sharing these slides? This is showing.
Yes, you can
Yeah.
share the slides, sir. Please.
Yeah. Is it visible now?
Yes, sir, visible. Just put it full screen, sir.
Yeah.
Yes.
Is it okay?
Yes.
Okay. So today we'll be discussing in the panel regarding the importance of quality of life and its monitoring in CML. So may I welcome my panelists. Dr. Prakash is here. Dr. Divesh.
Yes, hi.
Dr. Shweta. Dr. Preeti.
I'm audible?
Yeah, yes. Dr. Preeti.
Yes, sir. Good evening, sir. I'm here.
Good evening. Dr. Satyajit.
Yes, sir. I am here, sir. Good evening.
Okay, great. So just I'll minimize it. So just a brief introduction. Already the previous speakers have discussed in detail regarding the first line and subsequent treatment. So we know that the emergence of TKI has markedly improved prognosis of patients with CML. And based on the recent data from 2016, it is known that patients who are in CP-CML with a complete cytogenetic response and a sustained deep molecular response, they have a survival that is similar to age and sex match control. So here the key goal in such patients is to ensure a quality of life which is comparable to the general population. So to assess this, the US FDA has brought out a term called patient-reported outcomes, and it is actually the symptoms that the patient themselves report without any interpretation of the clinician in between per se. So we'll discuss these points in the following slides. So over to Dr. Prakash. So Dr. Prakash, what factors do you look into before deciding the first line treatment for a patient with CML CP?
So first of all, before starting, do a complete scoring. Presently, I am doing a ELTS, and then we see whether the patient is having any specific comorbidity and whether the life expectancy is affected by this CML. Then depending upon the transcript type and his profile, we also discuss with duration of therapy, possible side effects, and whether a TFR can be planned or not. These are different things which I discuss. And most importantly, I discuss the common side effects, the 3-4 common side effects which the patient may suffer in coming few months and which is going to hamper his or her adherence to the therapy. So quality of life is also discussed.
Okay.
Cost, TFR, these are the things.
Okay. Any other points any other panelists want to share? Dr. Divesh, you are mute.
So just I concur with Dr. Prakash, but I just want to add 2 more points. So suppose the family planning. So if the young age, suppose the age is 23 to between 30, so if wants to plan for family planning, so we can discuss and we can prepare the things for family planning as well as financial planning. So financial toxicity. So long term, if we want to plan any TKI, so financial planning is also required. So I just want to add 2 more points.
Okay, great. Any other points any other panelist wants to add? As rightly mentioned by Dr. Prakash, Dr. Divesh, these are all valid points. And I think to begin with, initially when we are seeing a patient, there are a lot of other complex issues going on. Definitely, most of the patients do respond, and quality of life sooner or later should be a part of our discussion in the subsequent visits. So as discussed, these are the main issues we need to discuss before deciding the first line treatment. So the next question I'll ask with from Dr. Shweta. So what was the impact of the use of imatinib in terms of quality of life that we know from the IRIS trial? Dr. Shweta is there?
Hello, I am audible.
Yeah. Yes, Dr. Shweta.
I am working as a pathologist, so I don't know so
Oh,
much
sorry.
about what is the
Okay.
impact of.
Okay. So Dr. Preeti?
So yes, the quality of life was significantly improved with the oral drug compared to the interferon alpha, which was given injectably, and also the adverse events was significantly lower with TKI. So the quality of life was significantly better with imatinib compared to this interferon alpha in the IRIS trial. Yeah.
Okay. And sorry, and anyhow, any means, so what we know from this data from the IRIS that imatinib was the drug which has reported the best quality of life improvement across the randomized trial reported to till date.
Yes.
But there is an issue with this trial. This QLI data was collected only for a short duration. So it was 12 to 18 months as per the trial. So the issue remains, this low-grade side effects with imatinib or either with any second generation TKI, they keep on occurring. So are we satisfied with this data that was reported, or do we need more? That is the question we'll be discussing. So we know that as compared to the previous standard of care in the IRIS trial, imatinib improved the quality of life. But any data in terms of how the quality of life is with the use of imatinib as compared to the general population, because we know that these patients live long and they have a good survival. So Dr. Satyajit, you can take this.
Yes, sir. So there is a literature in the blood journal. There is a group of study, like JMMA group, which had compared the quality of life of patients on imatinib with general population. They had shown that patients with the age of more than 60 years had equivalent quality of or similar quality of life as compared to the general population.
Yeah. Okay. So any other points, Dr. Prakash?
Yes, especially the in third, fourth decade population are doing bad compared to what we commonly think that elderly geriatric population is likely to suffer, but it is not so. And females somehow had more complaint of facial swelling and their calf pain. They are also major complainant.
Yeah. So again, coming to the part 2 of this question. So any particular group, as you rightly mentioned. So if you look into the trial, this JMMA group study that was published in around 2011. So one thing we need to note that these were the patients who tolerated imatinib. So these were the patients who took imatinib for close to 5 years, and at least 3 years they have to be in good complete cytogenetic response, and then they were compared to the general population. So again, patients who do not tolerate, they are already left out. So amongst these patients who tolerated imatinib well, they compared based on the SF36 health survey, and they showed that possibly the younger patients, possibly in the age group 18 to 39 years, they have noticeable impairment as compared to the general population with the use of imatinib. And also there was a difference in terms that females had worse health related quality of life as compared to males. And we see from the clinical practice that fatigue is the most common symptoms that these patients do acquire. So again, this study shows us that possibly in clinical practice, we should be more worried when we are planning treatment for such patients. So as you rightly pointed out, we without this data, we may think that possibly the elderly might be affected more, but it is in fact the younger population that is affected. So is there any difference of quality of life between the first and second generation TKI? So as Dr. Upender has brilliantly taken the topic, first one, but is there any point where we can say that one of the reasons to choose instead of imatinib, dasatinib or nilotinib, should we go for, means instead of imatinib, we should choose the second generation TKI based on the quality of life? So Dr. Divesh?
I think there is no such studies between first and second generation. I think in my clinical practice, I have not seen any difference between the first and second generation TKI. Even with this nilotinib as well as dasatinib, I think I have observed the same profile, fatigue sometimes and arthralgia. I have seen the two most common type of these side effects. But a few side effects are specific with this each and every drug. So I think I am not worried between this first and second generation TKIs for quality of life.
Any other views from Dr. Satyajit, Dr. Preeti?
I completely agree with sir. There is no data to say the difference. There is no head-on-head data of quality between the two first and second generation TKI. But in clinically, we don't see any difference. But there is no randomized control trial or head-on-head data. Imatinib versus another drug.
But I think imatinib is slightly more having those facial swelling and edema and slightly more muscle cramps with imatinib. When we switch to these newer drugs because of poor results, we don't see those side effects. Okay. Probably Hemant sir or Upendra sir can answer this one better.
But just my question, actually, this is the difference between quality of life. This quality of life encompasses not only physical symptoms, there is functional symptoms, mental, how the patient feel. So most of the time, I think personally, when I got this topic, after reading it, I think as such, in our clinical practice, what symptoms you mentioned are correct. Most of the time, even personally, I was not very careful regarding some of the domains. We are not looking for that because we are not actually taking any questionnaire. So for, let's say in the last 2-3 slides, Dr. Upender has shown a quality of life questionnaire that can be given to the patients. In a 2 or 5 minutes consultation, it is difficult for us to come to a conclusion that possibly we are covering each and every aspect of the quality of life. So most our as a clinician, what we mostly are looking into the physical symptoms. Actually, the whole means I think the point of this discussion is to look the quality of life in all the different domains for these patients. I think that will be the take home possibly for me as I prepared this talking. So instead of only physical symptoms, we should look into the other domains also, and we'll discuss in the following slides. So this is some data as rightly pointed out by the panelists. What we know that in the before trial, bosutinib was compared to imatinib in terms of quality of life, and there was no difference in terms of quality of life. What is known, and also as rightly pointed previously in the presentation by Dr. Upender, that patients who progress to blastic phase or say accelerated phase, their quality of life is impaired. And what is shown with the use of bosutinib, and possibly this will be true for most of the other drugs, that by giving an effective TKI, these patients' quality of life improve. So, but what is rightly said, there is very limited good prospective data in terms of quality of life and patient-reported outcome with both nilotinib and dasatinib. So, how do you think, Dr. Prakash, ki quality of life improvement will help in overall treatment outcome in CML-CP?
It's very simple. If the patient is comfortable and happy with the treatment, with minimum side effects, then he is likely to be more adherent. And our discussion OPD time was also enjoyable. Otherwise, patients keep complaining. He sometimes like to skip the drug. So adherence is important, and he may be counseled for discontinuation also if he is satisfied with the result and basically minimum side effects. So,
Agreed. Any other point? Any other panelist? Dr. Devesh, Dr.
I think
Preeti?
same adherence is main. I think first, if the adherence is maintained, then that we will think about the TFR, I think.
Okay. Agreed. So, what do you think, Dr. Preeti? This is question to you. So, we think that TFR should improve quality of life. So, do you agree that it is true for TFR that quality of life, if we give TFR to a patient's quality of life will be improved and possibly in all domains?
No, I will not agree with that. The side effect may reduce the side effect profile because of the drug. Yeah, it will come down because the drug is not there. But improvement in quality of life is not just physical, it is also emotional well-being, mental health, whether the patient is anxious about whether disease is coming back or not, getting repeated blood tests. So we don't have data, like the strong data that TFR improves quality of life. But no, I don't think it may help some. There is improvement in physical well-being, but I don't think the only physical well-being is the indicator of quality of life.
Okay, Dr. Satyajit, your take?
Yes, sir. Agree with Preeti ma'am. Completely agree.
Okay, Dr. Prakash?
so primarily, it is likely to improve. It may be a double-edged sword. In some cases, rebound symptoms and mental anxiousness, but that can be counseled and taken care of. So likely it is likely to improve because we are withholding the drugs, so some of the side effects may go down.
Dr. Devesh?
I think same with Prakash. I think two-way sword. I think one thing is anxiety level, but counseling can help. But otherwise, if TFR can be planned, so minimize the arthralgia, edema, as well as I think other mental well-beings. So he is treatment free, I think.
Okay, so rightly pointed by my
So,
panelist.
Deepak, can I
Yes.
add a comment if you permit?
Yes, sir.
So I think two more things I'd like to point out. One is the TKI withdrawal syndrome, which in the West is reported to be as high as 20 to 30%. I have about 50 plus patients on TFR, and I find that the incidence of the withdrawal syndrome is very low, not more than 10%. And I think one more thing which we need to think of is the really long-term toxicities of TKIs, all the TKIs, first generation, second generation, and these are toxicities which are still undiscovered. We know that all of them, in addition to the target TKI, like a BCR-ABL, they inhibit several other proteins also. And what will happen after 15 years of inhibition or 20 years of inhibition is not known. We just don't have data. Imatinib has been around for just about 20 years. If a patient takes the TKI for 30 years, then what will happen? Nobody knows that. There's no data on that. So
Agreed.
that again is a huge reason why if a patient is eligible for TFR, then we should think of TFR. Over.
Okay. So, as rightly pointed by sir, there is some data from a prospective study. The last study, they use various TKI and TKI discontinuation study. They monitored the quality of live data using the PROMIS score. What was seen and what was expected that the physical symptoms like the fatigue, depression, fatigue, diarrhea, these symptoms improved. Other symptoms like depression, sleep disturbance were also improved. But the domain where the most benefit was seen was in the physical domain, in the mental domain, and means other domains. There are 8 domains which they looked into. Some of the domains there was not much improvement. But again, this is a very good reason, and Hemant sir rightly pointed that there is definite data from a prospective trial that giving a TFR to a correct patient after discussing how the patient needs to be tested. This is definitely one of the things we can do to improve the quality of life. So the next question to my panelists. So what are the challenges do you face in clinical practice? So first question, do you, over to Dr. Prakash, then we'll go in this order. So do you monitor any quality of life, means as any questionnaire or anything routinely in your practice for patients with CML?
No. To be true, I don't use any questionnaire and nothing. I just specifically ask for 1-2 symptoms, diarrhea and cramp. And if patient sometimes tells on their own, then I try to sort that out. Otherwise, I usually don't ask anything. And there are so many symptoms which a patient may feel, which we even don't think of.
Okay.
There should be a questionnaire.
Okay. So Dr. Devesh, your
same with Dr. Prakash, usually not any questionnaires. And just I will ask to patient any regarding side effects, arthralgia, fatigue, any muscle cramps, or any specific side effect mentioned by the patient. So just I don't use any questionnaires.
Dr. Preeti, Dr. Satyajit?
No, we don't use any questionnaire. No, we don't use.
Okay, so just a point from the previous slide, in the Jimema trial, which enrolled patients who were taking imatinib for close to 5 years, when these patients were asked to fill this quality of life data, they were on regular follow-up with their physicians. Okay, in 30% of those patients on imatinib had severe symptoms in terms of musculoskeletal fatigue, 30% who were in regular follow-up. So some of the times what these papers and these means literature when I have gone through, possibly as clinicians in the limited time that we have, we possibly some of the times undermine these symptoms. So again, the possible answer to this is possibly utilizing some questionnaire like that was shared by Dr. Upendra, and possibly be more vigilant. If you notice, you can talk to the relatives ki any mood changes or anything patient is having, possibly this could be a way to, in addition to the physical symptoms that most of us oncologists or hematologists do in clinical practice, these are the additional symptoms or questionnaire possibly which we can use, which can help in monitoring this patient. So another issue with do you I have seen in the any data, do you think Dr. Prakash, across the trials, do you see any single questionnaire that was taken for reporting these quality of life data?
I have not seen, but I have read about this MD Anderson symptom inventory, like what we do for MDS and myelofibrosis, but I have not used this.
Okay, so the issue was that if we look into the last study, the Jimema study, all of these have used various different questionnaires. Okay, so it is difficult to compare one study with the other. In all, there are around 7 to 8 prospective studies which have utilized various different scores. So again, it makes it really tough to compare whether one particular drug or possibly one study is better as compared to other, or is more improvement is seen with a particular drug per se. So this is again a challenge which is there in monitoring quality of life. So just to summarize this panel, so we know that TKI improve quality of life of patients with CML, and this is there is no clear difference, as we discussed, in terms of quality of life between first and second generation TKI, and quality of life is improved in patients who achieve sustained TFR, but improvement is more in physical domains as compared to other domains. And monitoring of quality of life of patients with CML and timely intervention will improve treatment adherence and outcome. So thank you to my panelists for wonderful discussion. Over to Hemant sir for any remarks, sir.
So many thanks, Deepak, for a wonderfully conducted panel discussion, and I'd like to all the panelists, very learned panelists. And if I were to summarize in the next 5 odd minutes as to what we have discussed today, we had one initial really nice talk by Dr. Upendra Sharma, who set the stage for the various TKIs which are available, and emphasized on the toxicities of these agents, which again I think is very important. If you're giving a medication for a patient who, and it goes on for 5 years, 10 years, 15 years, 20 years, then you must monitor, actively monitor, look for toxicities. People are realizing now that over several years, the creatinine clearance of patients who are on long-term imatinib it creeps up. So that is something which you have to monitor. And of course, we know the pulmonary toxicities, pleural effusions, and pulmonary arterial hypertension with dasatinib, and the micro and macrovascular complications with nilotinib. So toxicity monitoring is absolutely vital. The second presentation was by Dr. Manoj Mahajan, and again, he highlighted on the group of patients who are resistant to imatinib, who are resistant to the second generation TKIs, and who are resistant to 2 or 3 TKIs, and the patients, the really bad patients who have the T315I mutation, and the options for treating these patients. So again, that is in a good 20% of patients, that is a unmet need when we talk about management of patients of CML. And then Deepak did a very panel discussion, very learned panel, the real life situations which all of us face when we treat patients of CML. The importance of TFR was very adequate brought out. And again, as we accumulate experience in our country with patients who've been on TKIs for 5 years, 10 years, 15 years, we will fine tune this TFR science even more. My personal feeling is that the guidelines, the Western guidelines, they are possibly too liberal for use for Indian patients. And like we are kind of trying and setting up a panel which will evidence-based or experience-based lay down guidelines for the rules for TFR in our country. So if anyone of you is interested in joining, then please let me know. So 2 more things. I have the privilege and honor to be on the ELN panel, and we are writing the 2023 guidelines. We've had several meetings. The document is in the process of being finalized. And again, if you think that there is something India specific or low middle income country specific which should be specifically mentioned in the guidelines, which you would like to see in the guidelines, then please let me know. So finally, I'd like to extend my deepest gratitude and thanks to our 2 speakers, Dr. Upender, Dr. Manoj, to our panel, our moderator of the panel discussion, Dr. Deepak, and our very learned panel. And I hope this all has been a learning experience from you. And from today's webinar, you will take back some important messages which will help you in managing your patients of CML. I'd like to also thank the Mice Idea team for organizing this virtual meeting for us. And of course, the Hematology Oncology Trust and Messrs. Novartis for facilitating this academic activity. So if you have any constructive inputs, criticisms, suggestions, please email me or WhatsApp me. And in the next get together, which we have, hopefully a physical one, I will try and incorporate all those into the program. So once again, thank you very much for your participation, for your presence, and have a very nice weekend. Good night.
Thank you, sir.
Thank you, sir. Thank you. Good night.
Thank you, sir. Good night.
Thank you, sir. Good night.
Thank you. Good night. Thank you.